Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCray.
According to the National Cancer Institute, more than 50,000 patients in the United States were diagnosed with cancer of the pancreas in 2016. The pancreas is an organ that lies behind the lower part of your stomach, deep down inside. And its job is to secrete enzymes to help with digestion and hormones that help manage your blood sugar, and that would be insulin. It's an important organ with several important jobs.
Unfortunately, cancer can develop in the pancreas, and when it does, it typically spreads rapidly to nearby organs, and it is seldom detected in its early stages. While pancreatic cancer ranks as about the 10th most common cancer, it's the 3rd most deadly. Only 7% of those diagnosed with pancreatic cancer live more than 5 years after their diagnosis.
Not very good odds.
No.
Less than 10%, 5-year survival. But new cancer drugs and new, more aggressive treatments are offering some hope to pancreatic cancer patients. Here to discuss is Mayo Clinic General Surgeon and pancreatic cancer expert, Dr. Mark Truty. Dr. Truty, thanks so much for being with us.
Thanks for having me.
Tell us your story about how you got interested in treating pancreatic cancer and studying it.
Well, probably like most physicians, they have some sort of a personal story. Back when I was in college, my father was diagnosed with pancreas cancer, had kind of classic symptoms of weight loss, abdominal pain, and eventually became jaundice or became yellow because blockage of his bile duct. At that time, he underwent kind of standard therapy, was diagnosed with a tumor, went to the operating room, had a suboptimal operation, had a prolonged hospital course, never went on to receive any chemotherapy, and within 6 months, he died in my arms.
Typical story, isn't it?
Yeah, unfortunately, and this was 20 years ago, and that still happens on a daily basis today.
I'm sorry, go ahead.
How old was he?
He was 56 when he died.
Were you interested in medicine and pancreatic cancer before his death?
Probably not at that point in time. So that was still, I'm in college trying to figure things out. But I think subconsciously that probably drew me to medicine and then ultimately into my current career.
And so you graduated from college. Where'd you go to medical school, and then what happened after that?
In Chicago Medical School. Then I came here for residency at Mayo. After I finished my general surgery residency, I went to MD Anderson in Houston for a 3-year surgical oncology fellowship where I focused in pancreas and liver tumors. And then I was recruited back here as a hepatobiliary and cancer surgeon.
MD Anderson, is that a good place? Did you have a good experience?
Yeah, it's a great place to train. You bet.
It's almost as good as here, isn't it?
Almost.
He's always given the needle. He can't help it. Yeah. So what causes pancreatic cancer? Have we figured that out yet?
No, not quite. Unfortunately, the majority of cancers of the pancreas are sporadic, so there's no particular cause. There are some risk factors. Smoking is probably the biggest risk factor. There's a small percentage of patients that can have a higher risk of pancreas cancer. So they either inherit some genes, so patients with BRCA mutations, those are associated with breast and ovarian cancer. Some patients with Lynch syndrome, and there's a subset of patients who have a hereditary form of pancreatitis that markedly increases their risk. But in general...
What syndrome? Sorry? What syndrome?
Hereditary pancreatitis.
Oh, but you said
Lynch syndrome. It's associated with colon cancer and a variety of other tumors.
Okay, so you've probably got some genetic abnormality.
Yeah, in a small fraction of patients, but the bulk, I'd say, probably 80 to 85% of patients are sporadic.
Smoking, though, the number one risk
Smoking
factor?
is the number one risk factor.
And you briefly mentioned the symptoms, and is it because that the pancreas is so deep down inside that it's already grown a significant amount and probably also spread before it's discovered?
You bet. There's a high correlation between stage of disease at diagnosis and tumor size. Unfortunately, most patients don't develop symptoms until the tumor is large enough, and at that point in time, the cells that are capable of spreading have already spread. If the tumors arise in the head of the pancreas and near the bile duct, those patients can present somewhat earlier, and they present with jaundice or yellowing of the skin. Tumors in the body and the tail of the pancreas typically aren't diagnosed till late, and those typically are weight loss and back pain. And at that point, most patients are already metastatic.
Is it the fact that it's just such a deadly cancer, or the fact that it's not diagnosed, that makes it so deadly?
I think it's probably twofold. And one thing that makes pancreas cancer so deadly is its biology. It's a very aggressive form of cancer. There's lots of mutations, and it tends to metastasize at a much earlier stage than most other cancers.
Metastasize or spread elsewhere.
You bet. So up to 50% of people at the time of diagnosis, we could already see on scans that it spread to the liver, the lungs, or the abdominal cavity.
So if we could come up with some sort of effective screening method, maybe it would...
That would probably have the best long-term impact on survival if you could diagnose it early. Unfortunately, there's no good screening tests currently available. Obviously, that's an area of research that Mayo and other institutions are actively working on.
What's the direction it heading? Like a blood test or?
Yeah, like any type of screening, some sort of a blood test, measuring cancer DNA in the blood or body fluids. The key thing is, though, it's still a relatively low incident cancer. So right now, even though we may be able to detect it from a cost-effective point of view, screening the whole population. So right now, all the screening assays are done at higher risk patients, those with multiple family members with pancreas cancer or some sort of genetic link.
So if you have a family history of pancreatic cancer, you're more likely, does that worry you?
So there's, in the general population, there's about a 1% to 2% risk of anyone in the general population of developing pancreas cancer. If you have one first-degree family member, that number jumps to about 4% to 5%. If you have two or more, then it's about 9% to 10%. So that's pretty dramatic. That's the risk of developing breast cancer at that point. So two or more family members, that's an increased risk. Those are patients we'd probably start looking at a little bit earlier.
You have siblings?
I have a sister, yes.
Okay, and I presume she's alive and well.
Alive and well.
So you've talked about the symptoms, and you talked about screening, which we don't have. But there's a lot of hubbub about a liquid biopsy, meaning you can take a sample of blood and not only determine whether or not the patient has cancer, but determine the site. Are we close to that? Are you working on that?
We have
also?
some new assays. Mayo's currently developed. So 90% of pancreas cancers have a mutation in the KRAS gene, and that's something it's pretty common. Mayo's now developed a new assay where we can measure what we call cell-free DNA, or circulating portions of that mutation within the blood. It's something we can measure. We're not quite certain how to use it. So right now, we're doing some pilot studies to see how that can make a clinical difference. Is that going to affect how we treat patients specifically? So that's kind of one of the exciting aspects that are new.
Is most of the research on early detection, or is most of the research right now on treatment?
Right now, most of the research is on treatment because we still have 50,000 patients every year annually that are being diagnosed. We have to come up with better ways to treat them, and that's kind of really dramatically changed basically since 2011. So for 3 decades, prior to 2011, the way we treated pancreas cancer is patients, have symptoms, they get a diagnosis. Unfortunately, most patients are already metastatic, and so they just got some palliative chemotherapy. The other 50% whose tumors we weren't able to see that it spread, we then classified them whether the tumor is localized to the pancreas, which was only about 10 to 15% of patients, or if it's grown outside the pancreas to involve critical blood vessels. Those tumors that were considered operable, again, a small fraction of patients we would take to the operating room. We'd perform operations on them, which are pretty complicated procedures. And then if they made it through and if they're in reasonable shape, we'd give them chemotherapy. We've done that for 3 decades. We've had no significant alteration in their outcomes. The reason being is that we know most pancreas cancer patients, their tumor probably has spread. We just can't see it.
And so how do you, once you suspect cancer of the pancreas, how do you confirm the diagnosis
Typically,
and determine whether or not it's spread?
So at that point in time, it's high-quality imaging. You want to get good scans of the chest, abdomen, and pelvis to see if there's any spread, and then you get a biopsy of the tumor in the pancreas to confirm it with the pathologist.
And when it spreads, where is the most likely place it's going to spread?
Most likely at liver, followed by lung, and then the abdominal cavity. Can exfoliate into the abdominal cavity.
And the survival rate, at least up until now, less than 10% at 5 years.
It has been. That number is moving due to the introduction of significantly more effective, what we call combinatorial modern chemotherapy. That's had the probably most dramatic benefit overall for all patients.
Yep, we want to talk about that when we come back. Time for a short break. You're listening to Mayo Clinic Radio. We're talking to Dr. Mark Truty, who is a general surgeon and a pancreatic cancer expert. Mayo Clinic Radio, back right after this. Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCray.
We are talking with Dr. Mark Truty. He is a general surgeon at the Mayo Clinic, Rochester, Minnesota, and also a pancreatic cancer expert. We've talked about the why of pancreatic cancer, and in fact, we still don't know. We've talked about ways to screen for it. Oh, by the way, I should mention that the number one risk factor is smoking, when we know that smoking isn't good for anything. Mm-hmm. We've talked about the symptoms, mostly abdominal pain. It's usually diagnosed late because it's so deep down inside and usually doesn't present with symptoms until it's already spread elsewhere. We've talked minimally about the treatment alternatives that are available, but we've got some hopefully new ones and better ones. And tell us about those, Dr. Truty.
So there's three main modalities of treatment for pancreas cancer. One is surgery, which we typically, historically only provided to a small fraction of patients. Second is chemotherapy, which also traditionally has been limited to ineffective therapies. And then radiation therapy. And so the key thing, what's really kind of dramatically changed in this, we've gotten very good at doing these operations. We've managing to get patients out of the hospital with low complication rates, low operative mortality. But again, this cancer needs more than a knife. Chemotherapy's pretty dramatically changed. In 2011, two significant papers came out showing the significant survival benefit of combinatorial chemotherapy, meaning multiple different agents have a significantly more effect on treating these pancreas cancers. And then radiation therapy has also evolved. You know, we have a proton beam, a variety of other ways to deliver it. The key thing is not which of these, it's how do we take what we have and apply it in the right sequence to get the outcome we're looking for. And I kind of compare it to my wife's chocolate chip cookies. She makes the best chocolate chip cookies. I have her recipe. I take the same ingredients. I put them in a bowl. I don't get her chocolate chip cookies. Why is that? Because she knows the right amount of each ingredient and in the right order to put them in and in the right manner to get the outcome we're looking for.
You really got to cream the butter and the sugar well.
And that's the key thing. And that's what we're trying to do here at Mayo is taking all these modalities that we have available, putting together in the right order to get the outcome. And what's the outcome? Everyone thinks, oh, we need an operation. We've been operating for 3 decades. It's not just the operation. The goal we're trying to achieve is to extend a patient's life with the best quality of life. Sometimes a big operation is necessary to get that goal. Sometimes a big operation is going to do just the opposite.
So the order was do surgery, then do chemo, then do radiation. Is that what typically patients were?
That's typically how it went. So what we're doing now is we're getting good staging exams. We're trying to figure out what's the best way to treat them. And currently what we're doing, we're using these chemotherapies prior to anything. So right at diagnosis, we have a diagnosis, we give them the chemotherapy.
And that's to treat the whole body,
You
right?
bet, because we know most patients, they probably have seeds or spread of the cancer, we just can't see it.
Sure.
Once we give the chemotherapy, we have to wait to have objectively measure whether it's working. If a patient's going to get chemotherapy, we have to demonstrate that it's effective. And that's where we also help with these blood tests and with our radiologists, because sometimes a CT scan doesn't show that the tumor shrinks. That doesn't mean it isn't working. A CT scan doesn't tell you if a tumor is alive or dead. So we're relying a lot more on metabolic imaging, PET scans, high-quality PET scans that we have here. Once we can demonstrate a significant benefit of chemotherapy, we want to maximize that because that's going to be the biggest determinant of how well people do long-term. Once we complete chemotherapy, we then move on focusing more on the tumor, and then we bring in radiation therapy. The purpose of radiation therapy is to not only treat the main tumor, but the surrounding structures, so that those patients who ultimately go to the operating room have a higher probability of me performing a negative margin operation. What does that mean? So in order for an operation to be effective from a cancer point of view, I have to be able to completely remove the tumor without leaving cancer cells behind. And that's where radiation therapy helps.
And you had mentioned the proton beam. Is that one of the uses?
That's one of the modalities that we're using. After radiation therapy, we take these patients to the operating room. Now, traditionally, we've only operated on patients whose tumors were confined to the pancreas. What we've really done here, and we do more here at this institution than any other center in the United States, is we operate on patients who are presumed stage 3 or unresectable, meaning their tumor grows outside of the pancreas and surrounds arteries and veins, which we typically would never operate on. Because of all the therapies they've gotten ahead of time, these patients now, we can offer them much more complicated operations. And our data would suggest that these patients are living significantly longer despite presenting with a higher stage of disease.
So tell us about going to the operating room and removing a portion, or I presume in most cases, all of the pancreas. It's a difficult operation, isn't it? I mean, it's hard to get to.
It's a very difficult operation. Even a standard pancreas operation is pretty complicated, has risks. And now when we add patients whose tumors extend outside of the pancreas and involve critical blood vessels, particularly arteries, those risks kind of dramatically increase. 1 centimeter in one direction or another may require a completely different operation and a completely different set of risks that come into play. So these are truly customized, bespoke operations. We've never done them before. There's no textbook on that, where each case is unique.
You obviously need an experienced surgeon.
Yeah, well, multiples. We work with our vascular surgeons as well. So we're doing operations that have no specific name.
And you can do it two ways. I mean, you can do an open operation,
Yep.
or you can also do it through endoscopically or through a small telescope now, right?
You bet. So that's the one thing that also Mayo's been leading in, is doing what we call laparoscopic or minimally invasive pancreatic cancer resections. And so
Is that harder?
I mean, when you first started, it is harder, but obviously when you gain the experience, the benefit, like anything minimally invasive, is a quicker recovery.
Well, especially because the patient then, since we're flipping around the order here, has undergone chemotherapy and radiation before they even get to surgery. So anything that requires less recovery time is good.
Yeah, absolutely. The key thing, it's a lot easier for patients to tolerate the chemo and radiation prior to surgery than trying to subject them to that after surgery.
Okay, so if we're flipping it around and surgery isn't the first thing that happens, how is this showing in outcomes for patients?
So we're seeing significant survival benefit. Now, you have to understand, we have to have a comparator. What are you comparing it to? What we used to compare it to is people we just didn't operate on. They just went on the palliative therapy, and those patients lived 6 months or less. So when we'd had no other therapies, we would just operate because that was better than nothing. The problem is our other colleagues in medical oncology and radiation oncology, they've gotten pretty good. So people are living up to 1 to 2 years without an operation. That's the standard survival with the old method of surgery. So if we're going to add an operation, we have to do significantly better than that. So we're about to publish our data on patients who we call borderline or locally advanced. These are patients whose tumors typically would be considered inoperable. We put them through our protocol of modern chemotherapy, radiation, and then a big operation. Many of these patients had multi-vessel, multi-visceral resection and reconstruction, so much more complicated operations. And the average survival of these patients is 4 to 5 years. That's all of them. When we look at these patients, we could then subclassify them and we could determine who does better than others. 3 things we found. Patients who got more chemotherapy prior to surgery lived longer. Those patients who had a blood test where we measure a tumor marker, if that number goes to normal after chemotherapy, those patients do best. And probably the most predictive is when we take the tumor out, we have our pathologist look to see if there's any living cancer left. Those patients who we take the cancer out and most of it's dead or all of it's dead, those patients are essentially cured. And we could stratify about how many of those 3 factors people get. And if you get all 3 of them, those patients, we haven't even met our median survival. So it's way beyond 7 years.
Wow, it all sounds very promising. It's a cancer that none of us want. What's the average age of the person who gets
The average age is 71.
Yeah.
But we're
71.
seeing even younger and younger patients, 40, 50 years old. So.
Well, there is hope. And thanks so much for sharing all that information with us.
bet.
And
Thank you
best
for
of
having
luck
me.
to you and your colleagues.
Thank you.